Okay, now we started recording. Assalamu alaikum. Hello everyone. Today our topic is very important topic. It's intrapatum care. I cannot express how much this topic is very important. We have at least you will get at least 10 questions from this guideline alone. You cannot enter the exam without knowing this guideline. It can come in the EMQ, it can come in the single best answer, everything you can find a question. The most important points that you have to focus on are the CTG interpretation, and the second part is the how to diagnose delay either in first or second or third stage, and how to deal with this. So these are the two most important points in this guideline. The other points can come, but can come as single best answer. But these 2 points usually comes as extended matching question. Because of the new formula, or the new how the exam now is being held, like it is computer based, they didn't include in the last exam, they didn't include any charts or any drawings. So, but you will not get a CTG strip like before. Like before, we can get a CTG strip, but now they will describe the CTG for you and will not give a strip. But we don't know what will happen. We don't know till now. We don't know how the next exam will be. So I'll try to make the CTG very easy for you, so you can solve any questions that come for CTG. So let's start. Okay, so first we have to choose the place of delivery. The places of delivery can be a home, can be freestanding midwifery unit, so it is a unit but by itself. All the people responsible for it are midwives, or alongside midwifery units. Also, it is a unit where midwives are the one responsible, but it is attached to a hospital. So you can easily transfer your patient to, or they can easily transfer their patients to the hospital, or an obstetric unit, which is the usual unit. This is the care in UK. I think most of us don't have this. Like I'll tell you, in Egypt, we either have a home or obstetric unit. We don't have a midwifery unit. I think also in KSA and other parts, some parts also have the same way. So, but in UK, they have these 4 sites. This one came before as a single best answer, I think. This is the risk for, this is when a patient, a multivirus come with who is a low risk. How much of the women can, okay, let's see. So we have spontaneous vaginal delivery for a multivirus, 984 delivered at home, and it is low in obstetric unit. This is how much of 1,000 people who attend this care, how much of them have had this one of this. This you have just to read this to know, at least to know that spontaneous vaginal delivery is more in home and less with obstetric unit. Episiotomy is lower with home and higher with obstetric unit. Also cesarean section, also instrumental birth, also blood transfusion, because in an obstetric unit you will have a low threshold for doing intervention, but at home you will have a higher threshold. So when you are at home, you will take your chances to the maximum. But in an obstetric unit, you already have other ways of delivering. So why take this risk when you can deliver more easily and more rapidly? That's why the risk here is with home birth is lower and higher in obstetric unit. Let's go for the second. Okay, this one is very, very important, especially this babies with serious medical problems. In a multibirth, it is the same for home and obstetric unit, and it is 3. And this number also came before. Here, for a nulliparous, you will see the same, that instrumental birth, cesarean section, blood transfusion, episiotomy, regional analgesia, all the interventions are more with obstetric unit and lower with home birth. And the spontaneous vaginal birth usually higher with home birth. This also is a very important. The serious baby with serious medical problem, it is more at home with 9 per 1,000, but 5 in the obstetric unit. Okay, so let's go. This is a reason for transfer. You have to know that the first reason for transfer is delay during the first or second stage of labor. This question always comes in the exam. This question came for us in the last exam, the January exam. It came. What is the most common cause for transfer to an obstetric unit? So the most common is delay in first or second stage. The second most common is meconium staining. Then you will have repair of perineal trauma. Then equally abnormal fetal heart and retained placenta, and also equally request for regional analgesia and neonatal for concern. Okay, so you have to know that the first cause is delay first stage or second stage, and the second is meconium. This is, you have to know this. The others, just you can read it, but to know for sure, you have to know the reasons. Okay, this one I just put here so you can know why these tables are there. They are taking like 4 or 5 pages of the guideline. These are the conditions that require the patient to deliver in an obstetric unit. This patient, we cannot take risks with her. We cannot let her. This is a high risk pregnancy. We have, when we say this patient is a high risk patient or a high risk pregnancy, she has a high risk pregnancy, so she must deliver in an obstetric unit. And these are the reasons. You've confirmed cardiac disease, hypertensive, asthma, cystic fibrosis, hemoglobinopathies, because she has a higher tendency for bleeding, immune thrombocytopenia, also higher risk for bleeding, bone will brand, all the hematological, she will have, good evening, Dr. Arti, hi. She will have a higher risk for bleeding, all the hematological causes. Endocrine, hyperthyroidism, she may go to a hyperthyroid crisis or thyrotoxic crisis during labor. Diabetes, you have to monitor her blood glucose during delivery, and you have to put her in insulin, and we will talk about this in the diabetic guideline, but you know, this is a high risk. She has to be monitored closely. Infections, like because most of these will also have a high risk of transmission of the infection, like hepatitis B and C, HIV, toxoplasmosis, chickenpox, rubella, herpes, TB. So if she is a carrier of group B streptococci, all these are high risk. Immune, you have systemic lupus, lupus and scleroderma. For renal, we have abnormal renal function and renal disease requiring supervision by renal specialist. Neurological epilepsy, because she can develop an epileptic fit during delivery. She can develop it. She may need extra work postpartum. Myasthenia gravis, previous cerebrovascular accident, because she may develop another accident, and now she will need to be admitted to an ICU. You don't have the risk to wait for transfer. Okay, GIT, like liver disease, psychiatric disorders. Because psychiatric disorders, she will have to be assessed by. We will talk about the mental health, but she have to be assessed antepartum, intrapartum, like antepartum in antepartum care. While she is coming for antepartum care, she has to be assessed. Antenatal care, she has to be assessed. Intrapartum, she has to be assessed, and immediately postpartum, she had to be assessed, because you know that she has a high risk of developing depression or psychosis within the first week. So she has to be under close supervision. Previous complications, like you have unexplained stillbirth or neonatal death. All these also puts her in high risk of recurrence. All these can put her in a risk of recurrence, and this for the current pregnancy also putting her at high risk. Previous gynecological, like myomectomy and hysterectomy, because hysterectomy, sorry, because she is in a high risk for rupture. These, you have to assess individually. A different patient will have different management. If she is in a critical case or advanced case, okay, she will deliver at an obstetric unit, but if she is all right and everything is well, she can deliver wherever she can. Also, you can read this in your own time. We don't want, this session is very long and I don't want it to be longer. Okay, now let's go for the communication. Always greet your patient and introduce yourself. Secondly, also approach anything that happened during the delivery, approach it with calmness and confidence, because if you panic, your patient also will panic. You have to be the one responsible to comfort her. She is coming and she is very anxious. She is very afraid. You have to be always comforting her. Okay, you have to knock on the door and wait for her to open, or wait for her to allow you to enter. Ask about how she is feeling. If the woman has a written birth plan, read it and discuss it with her. Also tell her about strategies for coping with pain, and we will tell these strategies after a few minutes. Encourage her to adapt to the environment around her, because she may have to wait for some time, and we will say after a few minutes how long can she wait with us. Ask her permission. Okay, I'm sorry, I have to answer this, okay? Sorry for this. You know, as I'm at work, so there may be some interruption. So sorry for this. Okay, encourage the woman to adapt to the environment. We said that. Yeah, ask her permission before all procedures and observation. Consent, consent, consent. Put this in your mind. Don't touch the patient without her consent. Don't touch her without asking her before. This can put you in a risk to, don't put, this will put you in a risk of being sued. You don't want this. So always before doing anything, you have to ask her permission, you have to ask her consent. You know that the assisted vaginal birth guideline was changed just because of this, because of the new laws about consent and permission. Okay, so this point is very important. Show the woman and her birth partner how to summon help, like if she has her water broke, like if she is coming without a rupture of membrane and her membrane rupture, if there is bleeding coming, if anything serious happened, how to summon you, how to call for help. Involve her in any handover of care to another professional, like your shift has ended and you have to tell her to see another specialist or another one who will take your place. You have to inform her about this. Maybe she don't like if you are a female doctor, for example, and she wants a female doctor and you are handing her to a male doctor, maybe she will not agree to this. Okay, I'm sorry, I will have to have 5 minutes and I will talk to you again. Sorry about this. This unicorn. Okay, so I'm sorry for this interruption. Okay. I think we covered this slide, so we will go to the other. Support. The most important is one-to-one care, and one-to-one care. This will go with us throughout every step of the intrapartum care. Either in first, second, third stage, you have to have one-on-one support, one-on-one care, and one-on-one support. Also, this particular word we will get it again in the guideline of assisted vaginal birth, because this single-handedly is the most effective way to decrease the incidence of assisted vaginal birth. So this is very important. And also, you should not leave the woman for a long time alone. She must have some companion. Okay. This care is just in all through the labor process. We have first to ask her about her wants and expectations. The labor or the process of labor is a natural process. Keep your hands to yourself. Don't interfere unless there's something wrong. So this is what we are aiming to mimic the nature. This is what we are doing. So as much as you can, don't intervene if the labor is progressing normally. You will just have to monitor. You are there to monitor, to look for any risk or anything abnormal. Okay? Tell the woman that first labor, if she is a nulliparous, that for nulliparous, the average is 8 hours. And for second labor, it lasts for 5 hours. This is the average. For us, this will not have a much impact on us. This is just to comfort her. But for us, what will really have a significance is how much or how long should first stage go and second stage go, and like this. And this we will talk about it again. Always encourage her to have a partner with her. Encourage to mobilize and adopt a comfortable position. Also, routine hygiene. Water, running water is enough. Like, ask her to take a shower before going to labor is okay with us. Soap and water, no extra measures. H2 receptors antagonist and antacids not routinely used or not routinely offered. We will know after some time what are the indications for this. Okay, so stages of labor. Some say there are 3 stages, and some add another stage, making them 4. But usually everyone is telling about the 3 stages of labor. The first, in which is the cervix relax and dilate and thin out. First stage of labor, this till from the start of the delivery, or from the start of contractions till the cervix is fully dilated. And for second stage, this is the stage of uterine contraction and infant delivery. This is from fully dilated to the expulsion of the fetus or the delivery of the fetus. And the third stage, this is the delivery of the placenta. Fourth stage is the first 48 hours after delivery, because in this we have the patient is very in a high risk for complications in this period. But not everyone is putting, the NICE guideline is not putting it as a stage of labor. Okay, so this as I said, first stage from onset of contraction leading to cervical dilatation to full dilatation of the cervix. We can put it in 2 phases, latent and active. Latent, which is the cervix from 0 to 3 or 4 centimeters, and active after 4 centimeters. And we are saying about active phase when she is more than 4 centimeters. Now she's in established labor. Second stage, from full dilatation to childbirth, we say there's a descending phase. They are saying there's descending phase and pushing phase. Descending phase from full dilatation to till she has the urge to push, and the pushing stage from starting the urge to push to the delivery of the fetus. Okay. Pain relief. This is pain relief throughout the delivery. Breathing exercises, immersion in water, massage, all these can reduce the pain in the first stage. Aromatherapy, yoga, acupuncture, we have no evidence if this can help or no, but if this lady wants it, we have no problem. Okay, go for it. Initial assessment, observation of the woman and observation of the unborn baby. We have 2 persons. We are not dealing with a single soul. We are dealing with 2 souls. So we are looking for the woman and looking for the fetus as well. For the woman, we are reviewing the notes, asking about the contractions, the length, the frequency, the strength. If there is any pain, and if she wants a pain relief, we have to record her pulse, blood pressure, temperature, and we have to do a urine analysis, because some patients may come to you in labor. This is her first contact with any medical service. She's coming for you. So you will measure this. Maybe she is she is hypertensive and she don't know. maybe she is preeclampsia and she don't know. Maybe she was hypertensive and now developed a preeclampsia and also she don't know. So this is routine for everyone: pulse, blood pressure, temperature, and urine analysis. And record if there is any vaginal loss. Observation for the unborn baby: we have to feel to ask for the baby's movement in the last 24 hours, and we have to palpate the abdomen to know the presentation, the lies, the position, the engagement, and the frequency and duration of contraction. We asked her, and we have to make sure with our own hands. Okay. Fetal heart monitoring. For any low risk woman, we will go for intermittent auscultation. Intermittent auscultation, we will know after a few minutes how frequently we will do intermittent auscultation throughout delivery. But for any low risk, we will not go for CTG. We will go first for intermittent auscultation, either by spinner stethoscope or a Doppler, handheld Doppler. This is what we are doing. This is the basic. We have to measure it for a whole minute after a contraction, and it must be immediately after a contraction. Why for a whole minute? To see any change, and why after contraction? To observe if there is any acceleration or deceleration, and we will know after a few minutes what is acceleration and what is deceleration. So this is a must. This is how we measure it. The second thing, you put your hand on in the mother's pulse to differentiate between her pulse and the baby's pulse. And anything you find, acceleration, deceleration, anything, record it. Put it in her record. Okay. When to transfer a woman? We will transfer her if there is, as I told you before in last session, NICE guideline is made for every medical personnel. It's not made entirely for us. It's not made for obstetricians. So you have this is also meant for midwives. So this is, or GB. Some GBs are doing vaginal deliveries. So when can they transfer her from a midwifery unit, home, or whatever, to a hospital? When? If there is, we also have some stuff with the woman and some stuff with the baby. For the woman, if her pulse is over 120 beats per minute on 2 occasions, 30 minutes apart, or single reading of either raised diastolic of 110 or more, or systolic 160 or more. This is a single reading, or 2 readings taken 30 minutes apart of diastolic of 90 or more, or systolic 140 or more. So single reading of severe hypertension, or 2 readings of moderate hypertension. And we will differentiate mild, moderate, and severe in the hypertension guideline. Plus 2 proteinuria, plus single reading of raised diastolic blood pressure 90 or more, or systolic 140 or more. So this is any patient with preeclampsia. Temperature 38 or more, taken single, or 37.5, 2 consecutive readings, 1 hour apart. Any vaginal blood loss other than a show, because this maybe was a previa. Maybe this was a low placenta and no one discovered it. There is a concealed abruption, whatever. So any vaginal blood loss, transfer her. Rupture membrane, more than 24 hours, she is in high risk for chorioamnitis. She has to be transferred. Presence of significant meconium, the baby is at high risk of aspiration, meconium aspiration. Pain other than the contractions. Any pain other than the contractions, refer her. Or any of this, we must record in the patient's notes. Observation of the unborn, abnormal presentation, transverse or oblique lie, floating head per abdomen, filled 5 per 5 per abdomen, suspected fetal growth restriction or macrosomia, suspected anhydramnios or polyhydramnios, fetal heart rate below 110 or above 160, deceleration on intermittent auscultation, because this will need continuous electronic fetal monitoring, reduced fetal movement in the last 24 hours. Okay, vaginal examination. As I told you, water is enough as antiseptic for us. We just want her to wash her vagina or external genitalia, only wash it. Ensure that the exam is really necessary. We must take her consent. As I told you, don't touch her without asking permission and consent. And you have to explain to her why you are doing this, and explain whatever finding you find. Another point, previously, before part 2, you have to submit an assessment of training form. So you must have 4-year experience. Now, no, after part 1, you can go straight for part 2. So some of the candidates are juniors. They haven't practiced obstetrics for a long time. So you have to know what you are looking for in a vaginal examination. You have to know this, because this not only will be necessary for your part 2 and also for part 3, but it will be necessary for you in your daily practice. In your daily practice, how will you manage a patient if you don't know what you are looking for? You must know what you are looking for while you are examining this patient. I didn't include it. You can search it. You can ask your seniors. You can ask anyone. Anyone will be more than happy to tell you what you are looking for in a vaginal exam. Indication for continuous electronic fetal monitoring. Indications for CTG. Yeah, it's a very long, very, very long indication. We have maternal and baby. For maternal, it is almost the same as the indication for transfer. And for the baby as well, it is almost the same. Okay? This one is very, very, you can take a screenshot of it. This one is very, very, very helpful. If you find one from group 1 or 2 or more from group 2, go straight for continuous electronic fetal monitoring. Suspected chorioamnitis or sepsis or temperature more than 38. Severe hypertension, oxytocin, and this is very important. Do not put the patient on oxytocin unless you put her on CTG. Presence of significant meconium and fresh bleeding. Here, for group two, prolonged rupture, moderate hypertension, confirmed delay in first or second stage, and presence of non-significant meconium. And we will talk later about what is significant and what is non-significant meconium. Here it is, significant and non-significant meconium. Light meconium or non-significant meconium, and there is significant meconium. Significant meconium, this is dark green or black amniotic fluid that is thick or tenacious, or any meconium stained fluid containing lumps of meconium. Okay, for Arabic people and especially Egyptian, so anything looks like ملوخية. This is exact description of it. Anything that looks like it, it is significant meconium. And really, if you saw it, it's really like this. It really looks like this. Okay, for this, we will go for a continuous electronic fetal monitoring, and we have to transfer, if she is in any other unit, we have to be transferred to an obstetric lead unit. Fetal blood sampling should be available, and you have to tell the neonatologist about this. Do not suction nasopharynx and oropharynx before the birth of the shoulder and trunk. Suction upper airways only if thick or tenacious meconium in oropharynx. Okay, if the baby in a good condition, we will check again after 1 hour and 2 hours, and then 2 hourly until 12 hours. And this is what we will look for: general well-being, chest movement and nasal flare, skin color, feeding, muscle tone, temperature, heart rate, and respiration. And if any vital sign is suppressed, we will do laryngoscopy and suction under direct vision by healthcare professional trained in advanced neonatal life support. Light meconium, we will consider, as I told you, for light meconium, we have to have other feature with it. Based on the risk assessment, as we said in the previous slide, baby is good, we will do also observation at 1 and 2 hours. This is what we will observe. If the patient, if the neonate's condition deteriorated anytime, call the neonatologist. Okay. Care and established labor. As we said, established labor, this means that cervix more than 4 centimeters. 4 or more. First, for controlling gastric acidity, as we said, H2 antagonists and antacids, not routinely used. We can offer them if the patient is taking opioids, or she have or develop any risk factor that makes her, puts her in a risk of general anesthesia. Inform her that she can drink whatever she wants, and especially isotonic drinks. She can eat light diet unless she has received opioids, or she can go for general anesthesia. Pain relief, we have a lot of methods for pain relief. First, we have non-regional, like the strategies we talked about it before: breathing relaxation, massage, labor in water. For labor in water, we have to monitor the woman temperature and the water temperature hourly, and ensure that the patient is comfortable and not becoming varicose. And we should assure that the water temperature is 37.5 and not above. All water baths should be clean, and there is a protocol for the disinfection of these baths. We should don't use injected water papules, don't offer acupuncture, but if you want them, we can do it. Support playing of music. Non-pharmacological, transcutaneous electrical nerve stimulation is not, we don't offer this. For inhalational analgesia, which is Entonox, Entonox is 50-50, 50% oxygen, 50% nitrous oxide. We have to make sure that this is available in all birth setting. It may reduce the pain, but we have to tell the patient that it makes you feel nauseated or lightheaded. Intravenous and intramuscular opioids. Ensure that Bethadine and diamorphia are there, but you have to inform her that it may cause drowsiness, nausea, and vomiting for her, and short-term respiratory depression and drowsiness for the baby that may last for several days. Inform her that Bethadine and diamorphia, they can interfere with the breastfeeding, and you have to administer antiemetics, as we said before, and avoid entering water within 2 hours of taking the intravenous opioids, okay? Or intramuscular. After taking opioids, avoid water births for 2 hours. Pain relief in labor, which is regional analgesia. Regional analgesia here, we do the epidural, most commonly the epidural. We have to tell, like, it is only available in obstetric units. It provides more effective pain relief than opioids, associated with long-term backache. Not associated, sorry, with long-term backache, not associated with longer first stage or increase the chance of a cesarean birth. Associated with longer second stage. So it will not affect the first stage, but it will increase the second stage, and it will increase, it have no effect in the cesarean section rate, but it have a higher rate for assisted vaginal delivery. It will be accompanied by more intensive level of monitoring and intravenous access, and so mobility may be reduced. Timing, you can give her anytime, even in the latent phase. This is a summary of the regional anesthesia, or sorry, regional analgesia. First, we have provide for all women who request regional analgesia. Should be, yeah, so regional analgesia should be provided for anyone who asks for it. We have to secure IV access. We have to give her a preloading and maintenance fluid infusion. No, now they are saying no, it is needed. Sorry, this is the old guideline, but it's needed. Epidural, sorry, we have to go this way. Establishment after each bolus, we have to measure blood pressure every 5 minutes for 15 minutes. This came a question before. This came as a question before. Provide continuous electronic fetal monitoring for 30 minutes. After 30 minutes, call anesthetist if the woman is still in pain. Every hour, check the level of sensory block. No routine use of oxytocin in the second stage. Encourage and help the woman to adopt any comfortable upright position. Epidural or combined spinal analgesia is recommended. Use low concentration anesthetic and opioids for establishment and maintenance. Don't use high concentration. Use combined spinal epidural for rapid relief of pain. Continue epidural until after completion of the third stage and any perineal repair. Either patient to control epidural analgesia or intermittent bolus given by healthcare professionals are the preferred methods of administration for maintenance of the epidural analgesia. Okay, if the patient who is on regional analgesia became fully dilated, we have to tell her to delay pushing for at least 1 hour or till she has the urge to push, because this will decrease the need for assisted vaginal birth. And I know that you will ask for the slides. These are from the NICE guideline. These are provided by the NICE association. These NICE guidelines, the old NICE guideline 2007. Previously, NICE guidelines, you would have the regular guideline and you will have a quick reference guide. So this is the intrapartum care quick reference guide. If you want it, tell me and I'll upload it to the group. Okay, so this one is already there. It's a guideline. I just took screenshots of this. Okay, let's go for the CTG. This is, I know this is the problem of many. And really, it is, yes, Dr. Radisa, do you have a question? You raised your hand. If you have a question, either put it in the chat or unmute yourself and tell before I start the CTG. And anyone who have a question in the previous, just tell it before we start. Yeah, okay, I'll upload it. Don't worry, I'll upload it, inshallah. After the session, I'll upload it. I have it, don't worry. Okay. So, CTG. Previously, me also, I had a very difficult time with CTG. For all those from third world countries like mine, we don't have CTG. Like in my entire district, we had there were only 3 CTGs, and there were only in the teaching hospital, no, in the university. Not even the teaching hospital didn't have them. They had it only in the university hospital. So this was a nightmare for me because I have never used it. But really, after this, it became very easy for me. First, you have to know this mnemonic, Dr. C. Bravado. If you want to interpret a CTG, you have to look for all these parts. DR, doctor, which refer to define the risk. What is the risk factor in this? Why are you going for CTG in the first place? Why? Is this preeclampsia, if she diabetic, there is intrauterine restriction, smoker, or what is the risk factor that made you do the CTG in the first place? Second is the contraction, then basal rate, baseline rate. We will go, I am not telling the numbers now because I will explain everything later. V, which stands for variability, A, acceleration, D, deceleration, and the overall risk. Yeah, this is define risk. As I told you, what is the risk factor? Why you opted for CTG in the first place? For maternal disease, like if she is diabetic, hypertensive, asthmatic, obstetric, like multiple gestation, post-date, previous CS, intrauterine growth restriction, premature rupture of membrane, congenital malformation, oxytocin induction or augmentation, because we said never put a patient on oxytocin unless you put her on a CTG. Preeclampsia, absence of prenatal care, like this is a patient coming for you for the first time, you don't know anything about her, and this happens a lot. Smoker, drug abuse, you have to know why are you doing the CTG. Contractions, you have to look how many contractions in 10 minutes. It should be from 2 to 5, not less than 2 and not more than 5. You have to maintain the contraction between 2 and 5. Okay? You have to look for the duration of the contraction and the intensity of the contraction. This is a CTG. Every big square is 1 minute. So you have to check how many in 10 minutes. 1, 2, so let's go from here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So we have 2 contractions in 10. Let's count again. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We have 2 in 10. So this is good. This is acceptable. For a baseline monitoring, 2 per 10 minutes is acceptable. We will not look for this now. This is here, this is the heart rate, and this is the contraction. Baseline rate. Baseline rate, this is what is the fetal heart rate. Now, usually we will go for the variability after some time, but usually it is fluctuating. It's not a straight line. No, it will go up and go down, go up and go down, go up and go down. But it will range. And we will tell about the variability after some while. This is the variability. But for the baseline rate, the rate should be from 110 to 160. And also you can look for it here. This is 60, 80, 100, 120, 140, 160, 180. So if it is from 110, which is here, between 100 and 120, and 160, so if it is lying within this, so the baseline rate is normal. Okay? Fetal tachycardia. Tachycardia means that blood, that baseline is more than 160, and this is in the case of fetal hypoxia, chorioamnitis, hyperthyroidism, fetal or maternal anemia, and fetal tachyarrhythmia. Maternal hyperthermia also can cause this. So maternal hyperthermia also can cause fetal tachycardia. Fetal bradycardia, this is a baseline less than 100. If it is from 100 to 120 in both dates, this is considered normal. So from 100 to 120 can be considered normal if this baby is post date, occipito-posterior or transverse, severe prolonged bradycardia, less than 80 for more than 3 minutes, indicates severe hypoxia. prolonged severe brady, prolonged cord compression, cord prolapse, epidural or spinal anesthesia, maternal seizures, and rapid fetal descent. This can cause bradycardia. Variability. This is, as I'm telling you, you will not find the fetal heart rate as a straight line. No, it will go up and go down, go up and go down. This variability should be from 5 to 25. So the normal variability is from 5 beats per minute to 25 beats per minute. If it is a straight line or almost a straight line, no, there is a reduced variability, there is something wrong. And if it is more than 25, no, there is exaggerated variability, and also there is something wrong. So variability from 5 to 25, this is good, reassuring. And look, don't stress yourself with this. Now I will give you something good you can memorize this with. Non-reassuring, if it is this, I will not discuss now, I will discuss later for the interpretation. And now telling you just the normal values and what does it mean. Okay, so let's go. Here, this is 10, 20, 30, 40. This is very long. But here, look, this is a normal variability. This is, we call acceleration. It's increased. But this is a normal variability. I will give you some. This one is made, this strip is made for demonstration, for teaching purposes. But I will put some actual CTGs to the group. I will put them to the group to see that you will find them more informative than this one. Okay, reduce the variability. Fetal sleeping. We know that the fetus can have sleeping cycles lasting from 20 minutes up to 90 minutes in some times. And fetal acidosis, fetal tachycardia, drugs can cause also reduced variability like opioids, benzodiazepine, methyl-dopa, magnesium sulfate. Prematurity variability also is reduced in gestational age less than 28 weeks, and congenital heart abnormalities. This is a reduced variability. Look, it is next to each other like zigzag. If you love to use a sewing machine, this is like a zigzag stitch. Okay, accelerations. Accelerations, this means that there is a spike in the heart rate. There is a spike in the heart rate. More than 15 beats per minute for more than 15 seconds. Acceleration, it's in itself is either its presence, its absence is nothing for us, but its presence is reassuring. If you saw acceleration, this means that this baby is okay. So its absence don't interfere with us, but its presence is a good indicator. Here it is. Like I told you, this, but this is an acceleration. Okay. Deceleration is the opposite. You will find a depression in the heart rate for greater than 15 beats per minute for more than 15 seconds. Deceleration, we have different types of deceleration. Deceleration indicates that there's a hypoxia. The baby is not getting enough oxygen. We have early deceleration. Early deceleration, it's a mirror image of the uterine contraction. You will have a uterine contraction, and in the same time, you will have a deceleration. Okay? This, with no concerning features, and for a few times, and this we will explain later, can be a normal variant. If no concerning features, and if it doesn't have any, if it's not lasting for a long time, this is a good, this is a normal variant and will not deal with it. And this is it. Look here, there is the contraction and here is the deceleration. Here is the contraction and here is the deceleration. This is not happening with every contraction. It's happening with every other contraction. This is, for me, if I'm commenting, but I'm telling you these are for demonstration purpose only. But if I'm commenting, this is a concerning feature because it's happening in 50% of the strip. It's happening with every other contraction. But don't stress yourself with this now. We are just saying what is this and how we can diagnose it. Okay. Variable deceleration. This will have no relationship with the contraction. Maybe may come with contraction, may come after contraction, may come without contraction. So it has no association with contraction. This is usually caused by umbilical cord compression. Okay, and the acceleration before and after variable deceleration are known as shoulders. I'll show you the shoulders. This is a shoulder and this is a shoulder. This is a shoulder. This is a shoulder. There will be acceleration, then after it there will be a deceleration. This is shouldering is a reassuring feature. If you find shouldering, this is okay. So this one don't have any relationship with contractions. The contraction is here and it is in between. The contraction is here in between. So it's not associated with any contractions. Late deceleration, this is the serious one. The peak of the contraction, and so it happens with the peak of the contraction and recover after the contraction ends. Okay. This is due to reduced uteroplacental blood flow due to maternal hypotension, preeclampsia, or uterine hyperstimulation. So here there is a peak, it started, and this is the acceleration. We said the shouldering that happens before the deceleration, and then the deceleration, the contraction finished, it will recover. Here is as well, there is the peak, it happened, lowered, and recovered. Prolonged deceleration is the deceleration more than 3 minutes, and this we will go for it again. Like this one, look, it is a very, very long deceleration, a big deceleration. This is for, I think, for more than 10 minutes. Okay, sinusoidal pattern. This is a very rare CTG pattern. This baby have a severe hypoxia, severe anemia. There's fetal or maternal hemorrhage. This baby, you have to go rushing for the OR. This baby has to be delivered immediately. So this is a smooth, regular wave-like pattern. Frequency 2 to 5 cycles per minute. The stable baseline rate around 100 20 to 160, no beat to beat variability. It resembles a sawtooth appearance. Yeah, this is, you know, there is no, it's going for waves, waves, waves with no beat to beat variability. Okay, so this is the how to describe a CTG, and this is how we lose points in the exam. Usually the CTG exam, the CTG question is usually very, very, very simple. But we don't know what it wants. There are two words, either describe or categorize. Describe, we will tell him a description. Either it is reassuring, non-reassuring, or abnormal. For me, I made this abbreviation is RNA. So if he asked you describe this, so you must tell him one of the three components of the RNA: reassuring, non-reassuring, or abnormal. Okay, so reassuring, this means everything is well and good. The baseline rate 110 to 160, the baseline variability from 5 to 25, no deceleration, or we said that variable deceleration with no concerning characteristics for less than 90 minutes. Okay, so I'm sorry, I made a mistake while explaining the early distillation. Early distillation, it's usually physiological. So I'm sorry for this. This point, please check it. I'm sorry, my mistake. So always physiological, the early deceleration. The stuff I was telling about it is really about the variable deceleration. The variable deceleration with no concerning features for less than 90 minutes. This is reassuring. Non-reassuring, the baseline rate from 100 to 109, or from 161 to 180, or less than 5 for 30 to 50, more than 25 for 15 to 25. So it's half the duration for more than 25, like for 5 minutes, less than 5 beats per minute, 30 to 50 minutes, more than 25 for 15 to 25, so half the duration. Variable deceleration for, we ended here with variable deceleration with no concerning less than, we will make it more for 90 or more. Variable deceleration with any concerning, if there is any concerning feature, and I will tell you what is the concerning features in the next slide, in up to 50%. If there is like no shouldering or stuff, it will be up to or 1 and 1 in every other contraction. With every other contraction, it can come like this. Sometimes the trick will come like this. He will tell you this patient has a variable deceleration with every other contraction. With every other contraction, this means that it is already in 50% of the strip. In up to 50% of the contractions for 30 minutes or more, or in over 50 in less than 30, or late deceleration in over 50 for less than 30. Okay, and abnormal below 100 or above 180, less than 5 for more than 50, or more than 25 in more than 25, or sinusoidal, variable deceleration with any concerning characters in over 50 for 30 or more. Here was less than, here for 30 or more. Late deceleration for 30 minutes. So once late deceleration became 30 minutes, it's abnormal, or acute brady single prolonged deceleration. Acute brady or single prolonged deceleration more than 30 minutes. What is the concerning characters? Lasting more than 60 seconds, reduced baseline variability within the deceleration itself, failure to return to the baseline, biphasic, it means W, it has two waves, no shouldering. Okay, category. If he asked for a category, we will go for NSP. Also, this mnemonic is made only for, sorry, but this will make sense for Arabs. It's not. So for category, it is not. So NSP, which is normal, suspicious, or pathological. Normal, all the features are reassuring, and we saw the reassuring features before. We will continue CTG unless it was because of something suspicious in the intermittent auscultation. Like if there is no indication for the CTG, we will stop. If there is indication for the CTG, we will continue. Okay, and for suspicious, 1 non-reassuring and 2 reassuring. We have 3 features. One of them, if one of them non-reassuring, it will be suspicious. What we will do first, correct the cause. If the woman is hypotension, have hyperstimulation, we have to correct this. Perform full set of observation, and we will do 1 or more conservative measures, and I will tell you in a few minutes what is conservative measures. Inform obstetrician or senior midwife. Document a plan for reviewing the whole clinical picture and the CTG finding, and document a plan for reviewing the whole clinical picture and CTG finding. Talk to the woman and her birth companion. Always keep communicating with your patient. Pathological, 1 abnormal and the 2 non-reassuring. So 2 non-reassuring or 1 abnormal feature, this is pathological. We will review by obstetrician or senior midwife. Exclude, so always he will tell you, the midwife called you for assessment or for reassessment. Exclude acute events like cord prolapse, suspected placental abruption, suspected uterine rupture. Correct any underlying cause like hypotension, uterine hyperstimulation. Start 1 or more conservative measure. Talk to the woman and companion. Keep communication. And if it's still pathological, after all these measures, obtain further view or offer digital scalp stimulation first. Digital scalp stimulation first. Digital scalp stimulation first. I said it more than 1 time because always we go for fetal blood sampling. No, first, before fetal blood sampling, go for fetal scalp stimulation first. And if fetal scalp stimulation have no effect, then you can go for fetal blood sampling or expedite birth. And expedite birth doesn't mean CS. It means re-evaluate your patient and see what will be more rapidly to do. will it be more rapid to do a CS or to go for instrumental delivery, which is more safe for your patient and for the baby? Always think like this. Expedite birth means this. And also take the woman's preference into account. And a point here I have to tell, because this was a very valid point for the exam, for last exam. Also, while taking her preference into account, take her mental status into account, because maybe she is not fit for consent. You have to check her mental state, check if she is in a condition to make a consent or no, to make a choice or no, because this was a valid point for the exam. This came in last exam. Need for urgent intervention: acute bradycardia, prolonged single deceleration for more than 3 minutes. This patient have to urgently seek obstetric help. If there has been an acute event, expedite birth, correct any underlying cause, start conservative measure, make preparation for urgent birth, talk to the woman and her companion, expedite the birth if acute brady persists for 9 minutes. If the fetal heart rate recover at any time up to 9 minutes, reassess any decision to expedite the birth. Okay, so we have to wait for 9 minutes. Conservative measures: encourage the woman to mobilize or adopt alternative position, offer IV fluid for hypertensive women, reduce contraction frequency either by reducing or stopping oxytocin if it is used, or offer tocolytic, and the tocolytic of choice is subcutaneous terbutaline 0.25 milligrams. Yeah, continuous electronic fetal monitoring, the same source I told you before, meconium stained liquor, fetal heart rate less than 100 or greater 110, greater than 160, deceleration after contraction, maternal pyrexia, fresh bleeding, oxytocin, woman's request, and for continuous fetal other risk factors if present, and these are the risk factors. You can screenshot it, or I will, inshallah, I will upload the guideline to the group. Continuous electronic fetal monitoring informs that electronic fetal monitoring will restrict her mobility, and every hour take document systematic assessment. Okay, this is the sorry. Yeah, this is how we manage how we monitor the patient in birth, and I will say this in a few minutes. If the trace is normal with oxytocin, continue until 4 or more or 5 contractions every 10 minutes. Reduce it if more than 10. Abnormal trace, if uterine hypercontractility, we will go for subcutaneous terbutaline, or if fetal death suspected with recordable trace, real-time ultrasound. Pathological trace, we will go for fetal blood sampling, and I will tell you how we interpret the fetal blood sample in a few minutes. Or if the pathological acute compromise, if deceleration is more than 3, we will go for urgent birth. Record keeping. This comes a lot. Record keeping, always keep every data of the woman in the with the trace. and everything that you did and every finding you found, keep it in record. Fetal, the trace, the CTG trace can be kept up to 25 years if it is if there was no abnormality, and indefinitely if there is abnormality. And you must have an electronic, you must have a photocopy of it stored store it as a paper form, and if it can be stored electronically, this would be better. Okay. Okay, sorry. Take paired cord blood gases only when concerned about the baby, either in labor or immediately following birth. Ensure the additional clamp for double clamping is available at all births. Do not make any decision about the woman care in labor on the basis of CTG alone. You have to take the whole overall picture, the preference, her preference, her feelings, the baby's movement, the well-being and behavior, maternal observation, any vaginal loss, medication she is taking, frequency of contraction. So look at her as whole. Don't look at the CTG alone. The CTG gives you an idea, but you are the judge. It's an electronic machine. It's not what is making the decision. You are the one making the decision. Intrauterine resuscitation. Don't use maternal facial oxygen therapy for intrauterine fetal resuscitation because it may harm the fetus. Do not offer amnio infusion for intrauterine fetal resuscitation. Fetal scalp stimulation. If the CTG is pathological, we will offer digital fetal scalp stimulation. If this leads to an acceleration, okay, so this is the response we are looking for, an acceleration. If no acceleration, we will go for the fetal blood sampling. Fetal blood sampling, we cannot carry it if there is an acute event like cord relapse, suspected placental abruption, suspected uterine rupture. You will waste your time. Time here is precious. The whole clinical picture indicates that the birth should be expedited, or contraindications are present like maternal to fetal transmission of infection, risk of fetal bleeding disorder. Be aware that for the woman with sepsis or significant meconium, fetal blood sample may be falsely reassuring, and always discuss with a consultant obstetrician. Discuss the results always with a consultant. Whether the fetal blood sample is appropriate or the results. Before carrying out or repeating fetal blood sample, start conservative measures and offer digital fetal scalp stimulation. Only continue with fetal blood sample if the CTG remains pathological, and this we will also have a flow chart for it. When considering fetal blood sample, explain why the test is being carried out, and blood sample will be used to measure the level of acid in bodies. So you will just tell the patient what we are doing and why we are doing it, and how we are collecting it, and the different, what will the result affect, how will the result affect our decision. If the fetal sample cannot be obtained, but there are fetal heart rate acceleration response to the procedure, this is an encouraging, and in these circumstances, expediting the birth may not be necessary. If fetal blood sample cannot be obtained and the CTG trace has not improved, we can expedite delivery. cesarean section or instrumental birth may be advised depending on the result of the procedure. And this is the result. Don't take fetal blood sample during or immediately after prolonged deceleration. Take fetal blood samples with the woman in the left lateral position and use either pH or lactate. For pH, these are the values, and these are the values for lactate. Normally, pH will be 7.25 or more, and for lactate, it will be less than 4.1. Borderline between 7.21 to 7.24, and here 4.2 to 4.8, less than 7.2 or less, and this is 4.9 or more. This table is very important. You have to know these numbers, especially, nothing especially, both are important, both are equally important. And this is how to go with after this. Fetal blood sample, if it is normal, repeat within 1 hour if the trace remains pathological. Borderline, repeat within 30 minutes, also if the trace pathological. Abnormal, go for urgent delivery. Fetal blood sample, this is the second time you are doing. If normal and unchanged, so we can get either normal, but the same risk, normal, borderline, or abnormal. For normal and borderline, if the trace is unchanged and fetal blood sample results stable, defer the third or defer a further fetal blood sampling unless additional abnormality develop. Or for borderline, you can go for a third fetal blood sampling, and for abnormal, you will go for urgent birth. Okay. When a fetal blood sample cannot be obtained, if the fetal blood sample is attempted and the sample cannot be obtained, but the associated fetal scalp stimulation results in a fetal heart acceleration, we said this before, this is a repeat. Okay. Pre-labor rupture of membrane. PROM. It has its own guideline. I put it here, but it has its own guideline. So I will explain it with its own guideline. Okay. Now we are in labor. First stage of labor. The duration for nully, it's 8 hours and unlikely to last over 18 hours. And for second and subsequent, it's 5 hours and more, unlikely to last for over 12 hours. This is how to monitor. This table is very, very important. What to look for and how frequently do we look for it. For first stage, every 15 minutes, we will check fetal heart rate. 30 minutes, we go for contractions. Every hour, we will go for pulse. And every 4 hours, we will go for blood pressure, temperature, and vaginal examination. And regularly, we will check frequency of bladder emptying. For second stage, every 5 minutes, we will check fetal heart rate. Every 30 minutes, also the contractions. For every hour, we only had, before we were only checking pulse. Now we are checking pulse, blood pressure, and vaginal examination. So vaginal examination in first stage every 4 hours, in second stage every hour. And every hour here will only be temperature, and the bladder emptying we should check regularly. First stage, we should use the bartogram. We should use the 4-hour action line. And we should support the woman and like this. For the second stage, assess the progress including the position, the station, and if the woman has full dilatation but no urge to push assist after 1 hour, we will see this. Say this again: discourage from lying supine or semi-supine. Consider the position, and hydration and burn relief. Okay. Delay in first stage of labor. When to suspect, when to diagnose, and what to do. This is a very important slide. Nulliparous and porous. Nulliparous, if less than 2 centimeters in 4 hours, for both. Look here and here. But here we will add slowing progress. Here we will suspect delay. Consider amniotomy of if the membrane are intact. Okay, and we will re-examine after 2 hours. So if it is less than 2 centimeters in 4 hours, we will reassess after 2 hours. If the progress is more than 1 centimeter, okay, let's go back to the routine check. If progress is less than 1 centimeter, here this patient have a delayed first stage. If the we will offer support and pain relief and electronic fetal monitoring. If intact membrane, we will rupture it, we will do amniotomy and re-examine after 2 hours. And repeat the same step as here. Okay, if the membrane are ruptured, we will see if this is or the progress after rupturing membrane less than 1 centimeter, we will nulliparous, we will consider oxytocin after rupture of membrane. Never, never, never use oxytocin with intact membrane. Put this in your mind. You will rupture the uterus. Okay. Boris, we will do abdominal palpation, vaginal examination before making any choice of oxytocin. Okay, and always with oxytocin, we will go for continuous electronic fetal monitoring. We will do a vaginal examination after 4 hours after oxytocin. So always after oxytocin, we will go after 4 hours. Okay. Progress more than 2 centimeters, vaginal examination every 4 hours. Less, we will do. We will consider cesarean section, amniotomy, explain procedure and what will happen. And this is oxytocin. Duration of the second stage. For nulliparous women, birth would be expected to take place within 3 hours of the start of the active phase or the active second stage. Diagnose delay if it lasts more than 2 hours. For multiparous, it's supposed to take place within 2 hours of active second stage and suspected delay after 1 hour. And this is how we deal for nulliparous, or we will delay if there is inadequate progress after this is suspected and confirmed delay after 2 hours, and here confirmed delay after 1 hour. Diagnose delay assessment and ongoing review every 15 to 30 minutes by obstetrician, and don't start oxytocin. Good progress, okay. And we will go for usual monitoring. Not good progress. Consider instrumental birth or CS. And for instrumental birth, this we will discuss in its with its topic. Intrapartum intervention to decrease perineal trauma. Don't perform perineal massage in the second stage. Either hands on or hands off can be used. Don't offer lidocaine spray to reduce the pain. Don't carry out routine episiotomy. Inform any woman with a history of severe perineal trauma that her risk of repeat severe perineal trauma is not increased compared with women having their first baby. Don't offer episiotomy routinely. At vaginal birth after previous third or fourth degree trauma. Third stage labor, we have either active management or physiological management. Active management involves package of care, routine use of uterotonics, deferred cord clamping and cutting, and controlled cord traction. Here we will not do any of this, no routine use of uterotonics, no clamping and delivery of the placenta by maternal effort alone. This one is important. Explain to the woman that active management, the nausea here shortens the third stage, but here the nausea is 100 per 1,000. For physiological, it's 50. Here, approximate risk, hemorrhage, more than 1 liter, 13, here 29. Blood transfusion, here 14, here is 40. For active management, we will give 10 units of oxytocin IM with the birth of the anterior shoulder or immediately after the birth of the baby and before cord clamping. Oxytocin alone has fewer side effects than ergometrine and oxytocin. After administration of oxytocin, clamp and cut the cord. Don't clamp the cord earlier than 1 minute. Unless there is concern about the baby, and clamps before 5 minutes. If the woman requests that the cord is clamped and cut later than 5 minutes, so support her decision. Okay, advise a change from physiological to active if there is hemorrhage or placenta is not delivered within 1 hour of the birth of the baby. Offer a change for also if the woman wants to shorten third stage, and do not use either umbilical oxytocin infusion or prostaglandin routinely in the third stage of labor. Diagnosis of delay in the third stage more than 30 minutes after active management or more than 1 hour after physiological management. If after physiological management, we will go for active management. If we will also secure IV access. For here, if the placenta delivered, okay. If not delivered, we will go for oxytocin. We will give 20 international unit in 20 ml of saline into the umbilical vein, proximal cord clamping, no IV oxytocin infusion. If oxytocin is effective, okay, we will go back to our routine. Oxytocin not effective within 30 minutes, we will give analgesia or anesthesia. We will go for manual removal if the placenta, but we have to give her proper analgesia. We discussed this before for the meconium. Care after birth, record temperature, pulse, and blood pressure, uterine contraction and lochia. Examine the placenta and membranes, assess their condition, structure, cord vessels, and completance. Transfer the woman with her baby to the obstetric care if the placenta is incomplete. early assessment of the woman's emotion and psychological condition, success voiding of the bladder, assess whether to transfer the woman to obstetric-led care after 6 hours if her bladder is palpable and she is unable to pass urine. Here we finished the guideline. We now at the 2-hour mark that we put to ourselves. So yeah, I prepared some questions, but I don't think we have time to do it today. Don't worry, I will add it to the next session. I know we still have 2 topics we didn't talk about, and also I will defer them to the next session. Inshallah, we will next session will be in the same time as I put in the I put the